Okay, let me see. Where is Parisa and Takashi? Hello.
Hello, hi.
Hi, how are you? Nice to meet you. Long
Thanks.
time no
I'm
see.
great. No, we see each other soon.
Yeah, we will
Yes.
meet each other soon, I hope.
Where is Takashi?
I
Today?
asked him to join.
Yes. Today I came very fast.
Very good. Thank you. Thanks for your dedication to the program. Hello,
Hi.
Takashi.
Hi,
Hi.
Hi.
nice
Hello,
to meet you.
brother.
Nice to see you.
Yeah,
Nice to-
thank you
I should
always.
say it's 22:30 in Japan, I think, in Tokyo. Is it right? You are at night, but we are in the evening in Tehran. I hope you had a good day.
Yes.
Okay, thanks for your coming. I hope there is no problem with my sound and my voice and my video. If there is any problem, please tell me. Do you hear me clearly?
Yeah.
I have your voice very good.
Very good, thank you. Okay, I want just to ask Takashi to start and introduce himself and talk a bit about himself, and then we will go to start the show because all of us know about Dr. Parisa. She was here before, and we just start with a brief introduction of Takashi. Okay, Takashi, go on.
Thank you. Thank you for inviting me.
Thanks for accepting
So
our invitation.
yeah, I'm so happy to be here. Thank you. I'm based in Tokyo, Japan. Endodontist. Mm-hmm. 15, 25 years dentist. Mm-hmm.
Very good. And
Thank you.
you have a board certified of endodontics in Japan. You have a degree in endodontics from board certified of Japan Academy of Endodontics. Is it right?
Yeah. Yes. Mm.
Yeah.
When did you grad? Me? Mm. Uh,
Okay.
I,
Uh, uh,
I'm sorry.
no problem.
Mm.
We can start with your case presentation, and if it is possible, you can start your case, and we will see, and then I will go to ask my question, and then we will go to see what is Paris's cases. But for presenting your cases, you have to turn your camera and use your front camera to show us your cases from your front camera. Uh, do you know how to do that? To do that in the live? Yeah, there is an icon.
Sure. My turn? Yes.
Very
Can
good.
you?
Yeah,
Mm?
we can see it, but you have to go away. You have to go further because we only see a part of your screen, not the whole screen.
Yeah. This is just size.
Oh, okay, no problem.
Yeah.
Go on, and I will
Okay, so
tell you
good.
about the quality. Good, no problem.
Okay. Clear?
Go on.
Okay. Oh, let's start. First of all, I can do endodontics, but I cannot do well in English. So, pardon me if you can't understand my pronunciations, but I'll do my best to talk to you all.
No
Yes,
problem. Feel
okay.
free.
It's good.
Good.
Thank you. Today, I'd like to present two cases. Both of them are about MTA filling for open apex in mature teeth. Let's start with case one. Case one is a C-shaped canal. Uh, Almost all Asian people have C-shaped canal. Mm, have you seen my full-size pictures before on Instagram? Because my Instagram posts are all trimmings.
Yeah.
As you
I
can
see
see,
that. Yeah.
mhm, as you can see, this tooth has a periapical region and is contacted with the wisdom tooth.
Exactly.
Let me show the case protocol. Periapical status was acute apical abscess. He had very severe symptoms. On day one, I managed to remove the pus and control the bleeding. I prepared and irrigated for C-shaped canal using ultrasonic tips. On day two, you can see there's no symptoms and pus. So I did the final rinse and MTA obturation. Let me show how to do MTA obturation using my own technique. This case I'm showing is from another patient, but I'm using same technique. Also, when filling bioceramic materials, it's important to avoid acidic environments because it causes hardening failure. First, I applied MTA cement that's a little wet and soft using surface tension. Please note that super dry is not effective. Push a little and as possible as not overfilling. If you fill the material 2 to 3 millimeter, then the result is wet. But if you use the paper point rightly, it will absorb the water and it will be hardened. It needs incremental filling, layering filling to prevent air bubbles. You can press from this point. And this is a cotton pellet. Filling to avoid extra bursts. Then clean the walls with moist cotton pellet for the next adhesive operation. Lastly, moist the cotton pellet and place on the MTA. Then put the temporary fillings. Okay. When doing MTA filling, I usually use MTA former. This is former. When MTA is pressed on the former, scoop it with the condenser, and it will form into a rod shape. The rod-shaped MTA cement can easily be inserted into the canal. If it's convenient for the patient, I would increase the volume of MTA and still wait for it to fully set it, because I think to withstand push-out strength, I believe the monoblock would achieve. That's why I don't cover the unseated MTA with gut aperture. As you can see, this is post-op, and here is 9 years with follow-up. This case had complex anatomy in periapical, but you can see bone regeneration. Okay.
Takashi, can
No.
you show us your radiograph separately? Yeah. Please move your camera closer to each photograph, radiograph before and after 9 years and before 9 years, post-operative.
No,
Is it possible?
fixed. No.
You can move your phone.
Okay.
Yeah, use it by your hand. Yeah, freely. Yeah.
A post-op.
Very good. It was the post-op, and then 9 years later,
9 years.
it's completely healed. It's completely healed. Very good. Thank you.
Thank you. Okay. Now, let's move on to case number 2. In this case, the periapical region had a large empty bone cavity. For that reason, I placed the collagen matrix into the bone cavity. Let me show the case protocol. I always use cola coat for internal matrix to prevent the irrigation solution remaining in the bone cavity. I use sterile water for final rinse. Let me show you a technical video. The patient has an empty bone cavity. Collagen material fills into the bone cavity with humidity being controlled. I use condenser. I put on at a time for several times. When checking the outline of apical foramen, the collagen serves as a stopper. MTA now can withstand the filling pressure. You can follow the MTA filling technique in case 1. This is an example of fully setted MTA before the build-up. As you can see, these are pre-op and post-op and 30 months follow-up X-rays. Collagen was absorbed and the bone is healing nicely.
Very good. Can you again show us every radiograph? But put it away. Yeah, it's good. It's now good. Yeah. Show us your radiograph. please. Very good. It's post-op, and this is
13
the follow-up.
months. Yeah.
30 months. Very, very impressive.
Thank you. Do you have any question?
Very good. So you have finished your presentation, and I
Yeah.
just want to thank you for your great presentation. Two amazing cases. I have many questions about the cases, but if you let me, I will ask Dr. Parisa to start her cases. I just started the show very quickly
Dr.
because
Ali, you agree with me that I think because we will forget Takashi's cases, like I have about 2 or 3 questions about the cases that recently were presented by Takashi. I think maybe like we can set the questions and Takashi can think about the questions and then I can present my own cases. Do you agree with this?
Yeah,
Because,
okay. We are flexible about
now
the plan.
we have a lot of questions that we can ask. Like just I think case 1, dear Takashi, that you had a kind of infection around the root. I mean, your first case. I really want to know why did you use MTA for the apical seal?
Apical seal? Mm-hmm.
Yes, in your first case.
Yeah.
I will write the question here because we will go for the question at the end of your presentation. I will write it and then if we forget it, I will ask it again.
And another question that I have is you told that always you use sponge or collagate so you can control the length of the MTA so it will not extrude out the root. I want to know that why always? I mean, is it necessary that we always use a kind of a sponge at the length of the root so we don't have extrusion? This is another question that I have. And this was the second question. And third question, I have another one. I saw in your video, dear Takashi, you use an instrument to insert the MTA in the root canal. I want to know what's your instrument that you were using in that video, I mean. Okay? Dr. Ali, I think it's enough. These questions were correlated to Takashi's cases. If you want me to start, I can start my cases right now.
Thanks for asking your question. And I just want to say that I started the session very quickly because I don't want to waste the time for presenting the cases. But I want to say that we are here on the behalf of EndoLeadersShow team. And this is the 5th session of the EndoLeadersShow program. And I am honored to be the moderator of this session. And we have the chance of having Dr. Takashi from Japan and Dr. Farisa from Iran to talk about the art and science of using MTA in the endodontics. We have passed the first part of the session, which was Takashi's presentation. We were very happy and we were very impressed about the cases he shared. And we have received some questions from Dr. Parisa, and we will go for the question. I also have some questions from Takashi because he's very talented in using MTA at every place he wants. This is a very good talent and very good skill that you can use MTA in every case. I think this is a skill and we have to mention that. But I don't want to talk too much, and I give you the microphone. I give the microphone to Dr. Parisa to start her presentation, and we are all ears.
I'm honored to be thanks, dear Dr. Takashi. First of all, I'm honored to be here, and I want to speak about the art of using MTA in endodontics. The first case that I want to present is this one, as you see. In the left side at the pre-apex. This is a case with a history of trauma, as you can see. In the apical segment, even the length of the root has been shortened. I zoomed it in so you can see better. And you can see the difference between the right central and left central. We have resorption, external resorption over here. And this patient came to me with the age of 17-year-old. I mean, he was not that old, but the trauma, the history of trauma was for about 7 years ago. So what did I do? I decided to use MTA in this case. As you can see, I used MTA because of the sealing of the apical segment, because I wanted to have a good seal over there. Dear Takashi, I didn't use any barrier over here. I just placed MTA. I will talk what's my technique, but I just wanted to share this trauma case with you guys. A 17-year-old patient that the history of trauma was about for 7 years ago, and I used MTA completely in the root. This is one of my cases. I haven't followed up this case because it was done recently, I think 1 or 2 weeks ago. And because of that, I don't have any follow-ups for this one. Now, I want to say in some cases of mine, I should play it. I will share my next case, and then I will
no problem.
share that video that I done with MTA and which instrument I used. In this case, as you can see, it was a 10-year-old patient with open apex, and this boy came to my dental office. You can see the apex. I've done a kind of vital pulp treatment for this patient. I say apexogenesis, apexoregeneration. Some words I use, it depends on the case. And I followed up this patient. As you can see, this is a post-op radiograph, and this is a follow-up after 10 months. You can see definitely it's very obvious that the root has been closed after 10 months. And now my patient is symptomless and in a very good condition. Then this is my second case. And after this one, I had a case that I want to present. It's a retreatment case, as you can see, with a very big and large lesion around tooth central and lateral. The lesion is very big and huge. I decided to retreat this case. I use MTA for the apical segment. And I treated the tooth number 8 also. This is a follow-up after 2 years. I've zoomed and you can see a lot of bone has regenerated around my roots. My patient is symptomless, and in the radiograph, we have no sign of symptoms of lesion or infection. And I want to say in this special case, the patient didn't came because of the checkup or follow-up, but she came for the second premolar. As you can see, the second premolar had pain, and she came for root canal treatment of this tooth, and I done a follow-up for her. So I saw that this huge lesion has been regenerated, and I was satisfied with this case. Also, I used MTA in this one. Sometimes I use MTA under a microscope. We will speak about it. And my other case is a very challenging case that I want to present. It's a trauma case also. In this case, as you can see, we have a horizontal root fracture in the root. So I splinted this case. I don't know that you know or not, but in these kinds of cases, they say that the coronal part will kept vital, and the apical segment will the apical segment will be vital, and the coronal segment needs treatment. But in this special case, I could negotiate all the canal, and I put the file into the root canal to the working length. I used MTA, as you can see. This is my post-op radiograph. I don't want to speak about the trauma schedule and how the patient came to me, because I splinted it, and the patient had, I think, a splint for about 3 or 4 months, and it had its own protocol. But because of the ELS and this program, I decided to follow up my patient after 2 years. As you can see, these are my post-op radiographs after 2 years. And the tooth is not mobile. The mobility is completely zero. It's normal. And I saw that the patient is in a very good condition. The aesthetic was good, and the periodontal condition was good. In the radiograph, you can see it has a kind of healing. I don't know what we say to these kinds of healing, because I haven't done this a lot in my office, but I used MTA in this case as an intracanal splint. And I searched in the articles and papers, and I noticed that we can use MTA as a kind of a splint, so we can attach the segments of the root that are, fractured. And I'm so happy for this one. Maybe I will case report it, because it's such a wow. And this was about case 4, a hybrid between trauma and using MTA, not just in the apical segment, but in the mid-root segment. And I shared this case recently. As you can see, the apical segment had resorption. I used MTA in this case, and this is an 8-month follow-up. You see the lesion is getting smaller, and it's in a good condition. Dear Dr. Ali, I
Very good.
have more cases. I think it's enough for now
Yeah, sure.
because
Thank you.
I've done a lot with MTA, and I think it depends on the case and on your question. I can play the videos or some cases that I've shared right now. We can answer and collaborate on the cases if you agree, because I think we will
Yeah,
get a
thank you.
bit.
Thanks for your amazing cases. Especially, I really liked the case of trauma that you were able to manage the whole root canal system, because it is very hard to find the main pass through the fracture area, and it is very hard to negotiate all the root canal system. But you were able to completely seal the coronal and apical segment. This is very technique sensitive. And in many articles and literature, it is not suggested to do such treatment because they say it's
Exactly.
very technique sensitive. You may worsen the situation, but
Exactly.
you have passed the literature and you do something beyond our knowledge, and this is very impressive and important. And we cannot suggest all the audiences to do such treatments, but they can consider it as one of the options, specifically if we have any periapical lesion at the apical segment, because the apical segment can also have necrosis, and we have to manage it somehow. Some go actually in
Exactly.
such cases, yeah, in such cases, some actually many endodontists, based on the protocol, goes to only manage the coronal segment orthograde, but they remove the apical segment if they see any periapical lesion. But it will actually worsen the long-term survival of the tooth, because you have a short root and short crown to root ratio, and this is not good for the long term of the tooth. But you were able to manage it very impressively and very actually magically.
But I
Thank you.
forget to say something about the horizontal root fracture. This case was previously done, a general dentist done it previously. I mean, when the patient came to my office, I didn't saw the treatment of, and it had a kind of temporary filling on the, I mean, a palatal segment of the tooth. But I decided, because of the age of the patient, and her parents were very anxious of the tooth, because it was
Sorry, we lost the voice. Let's wait for.
very worried,
Okay.
maybe that the tooth will not be saved. Because of that, I try to start the treatment, but I prefer to do these kinds of treatments from the first, not like previously initiated, because it's more challenging.
Yeah,
The
exactly.
challenges, yes, and the prognosis of the tooth will be lower.
Exactly. That's the point of managing such complicated cases. Thank you. If you agree, I just want to ask Takashi to answer Dr. Pariso's question. I will read the question again, and please answer the question. Takashi, we will learn about your concept. The first question was about the reason of using collagen, and about the reason of using MTA in your first case, because the first case, as you said, there was a large lesion, and we want to know what's the reason behind using MTA as the filling material. Why don't we use actually gutta percha to upgrade those root canal system? Why should we use MTA?
Sure. Thank you, Dr. Parisa. Interesting presentation. Thank you. Thank you for the question, Dr. Ali.
My pleasure. Thanks for your answer.
For question one, it's because it was difficult to tightly fill it with gutta percha.
Are
I
you
use
making because of the size of the apical gauging, and you said because we have a large apical area, we have to seal it with MTA because it is better to seal such a great apical area with MTA than using gutta percha.
Yes,
The
exactly.
MTA will improve the sealing of the apical segment. Very good.
Dear
Okay, and the second
Takashi,
question.
can I ask you, do you have a number for the apical segment? A
80?
number for the apical segment, like which file do you like? You told me that we all the endodontists and all the general dentists use gutta percha, and because of the apical size, I understand that you told the apical size is important. Which size? I mean, what
Is
size?
it?
Yeah.
Do you have a
Very,
size in your mind? Like 60,
yeah, very good
80,
question.
70, which size do you prefer? After that, you should use MTA or other bioceramic material.
Yeah, very good question. Uh, my criteria is number 80, ISO 80.
80?
80. Yeah, until number 80, I can use gut culture for root canal filling by continuous wave condensation. And when there is apical stop, it's important.
Very good.
Dr.
Yeah.
And have you searched any recently papers or articles? Because I really searched the number, and I couldn't find a certain number that that we can say, okay, after this number we won't use gutta percha, and we will use like these kinds of materials, and beyond that, no. Because in my mind, like the number is like 60. You know what I say? What I mean?
Yeah.
I think that till the number 60, we can use a hand file, cuff file, I mean, to estimate the apical size. And beyond 60, maybe we will not have that kind of seal in the apical segment, and maybe like we can use MTA or other materials, so we can have a kind of seal. I mean, is this 80 number that Takashi, you say, is it in an article, or just your experience tells number 80?
Yeah, that's a good point. I research many literature.
Yeah. I've read some articles. We have two different concepts: strict and loose concept in using MTA for the obturation. If we use a loose criteria, we have the AT size, apical size to use MTA. But we have also 50 and 60, as you mentioned in the articles and the literature. It depends on the situation and the cases. We have previously many cases that were managed by using master gutta percha, joint gutta percha, which was the combination of some 1, 2, or 3 big gutta percha to completely seal the apical segment. But nowadays we know that having an apical area larger than size 80, it is not reasonable to use MTA because we should consider 80 as the cutoff point. We have also 50 or 60 in the literature, but the 80 is very actually repeated in the many articles.
I agree.
And I agree with the Takashi's concept.
Yes.
And the second question was about why do you use a sponge in many cases? We want to know the reason of using a sponge or any membrane in the apical area to use MTA over it. Why?
Thank you.
Okay.
Yeah.
Oh my God.
yeah. Color coat? Yeah?
Yeah,
Yes.
color code.
Yeah. I got the idea from Dr. Begeholtz from his book, textbook of endodontology.
Very
Maybe
good.
he cited Dr. Lemon's article. He used color code.
So you follow his
You mean
concept because
the
he
material color code, or why you use it in all the cases?
Yeah.
uh,
Yes.
in that textbook it was mentioned to use color code in every cases, and you follow this concept because it was written in that textbook. I haven't read that book. I have to read it and to see the reason behind why using color code in every cases. But color code is a very good material that will help us to control the working length of the MTA, specifically in the tooth and in the situation that we don't have any stop, or we have a very big large apical size in order to control the working length. But it is very technique sensitive. And the third question was about the name and the type
Sorry,
of the instrument that you,
Dr.
yeah,
Ali, can I say something?
yeah, go on.
Except besides of color code, we can use PRF,
Yeah,
placket
exactly.
rich fibrin. Yes, this is also a good material that we can use in the apical segment, so we don't have extrusion of MTA, and we should notice this one also. It's a good material. All of them are from collagen and absorptive.
Exactly, because if you have the experience of using MTA in very big apical size, you will see that how many and how much you put or place any bioceramic materials in the apical area, you will push it, and you will not reach any actually apical seal until you use any apical barrier, and this will help you to have a better apical seal. But
Exactly.
it is very technique sensitive, and I will ask it in the future about how to use color code in the apical area. But I just want to ask the third question about the type of the instrument that you use to carry your MTA or any MTA-like material in the root canal system. What was the name of the instrument?
Yeah. Nice question. I always use condenser for MTA filling.
So you use a condenser to carry the your MTA into the root canal system, and the instrument was a condenser. But it
Yes, condenser.
but it should condenser, but it should be micro condenser, because when we have narrow canals, we will not able to place a large condenser to place the MTA into the root canal system. We have to use a small instrument. Was
Yes,
your
your condenser
condenser a
was
micro?
really tiny. Your condenser was really tiny that you used it in the root canal.
I think it was a micro condenser, yeah,
Yeah,
because of
micro condenser.
the size of the instrument that I saw on your video. It was very tiny, and it was very good
Exactly.
for placing. Yeah.
Yes, it
And
is.
I think you told that we shouldn't use paper points. Why? Takashi. You
Absorb the water.
I think I heard that you told us that, you know, I use paper point for
Yeah.
putting MTA into my root canal. And when you told, I heard that you told us that we shouldn't use, paper point because it absorbs water. I really don't know, but I think I heard that. Yes or no?
Yeah. First time I use surface tension. The 2 to 3 millimeter filling absorb the water and compress.
You wait to the apical segment 2 or 3 millimeter apical segment absorb the water, and then you compress the apical area with the paper point.
Yeah, my technique.
Yeah, it was a technique. This is a conflict of concept, and we have different concept of using MTA in the apical segment. There are many actually concepts that claim that if you use paper points in placing the MTA, you will absorb many of the moisture of the MTA, and the final setting will be hindered, or we may have an onset of apical segment of the MTA plug. We have to wet the apical segment with a paper point or with a wet cotton roll, and we have to re-wet the apical MTA plug in such cases if we use paper point in order to condense the MTA. I agree with Takashi because of the absorbing the moisture with paper points. Okay. I want to ask my question. I have many questions, but because of the limitation of the time, if you agree, I will ask it very fast, but I want to answer my question as short as possible to be able to answer all the questions. My question is about the impact of using magnification. Is it necessary to have magnification to manage all the MTA cases, or it is not necessary? It is just adjunctive instrument in order to place MTA in any places in the root canal system. Is it necessary, or it is just an extra option?
Yeah. Me?
Yeah.
Yeah, good
Please
question.
start with Takashi. Yeah.
Yeah,
Is it
yeah.
necessary to have? Yeah.
Yeah. Ideally, this should be done under the microscope if possible. I generally operate at 7 to 10 times magnification for perforation repair.
Very good.
Thank you.
Use
What is your idea, Parisa? Very good. Parisa, what is your idea about
Dr.
the
Ali,
using of magnification? Is it mandatory, or it is just a good option if we have? Can you hear me? Parisa?
Okay, magnification?
I asked Parisa to answer my question about the use
Dr.
of magnification.
Ali, you know, I really agree that when we see, we can do it more better. I mean, whatever it is. It's a missed canal. I don't know. It's placing MTA in the canal. It's sealing the perforation. Whatever it is, okay. When I see, when magnification is there, I mean loops. I don't know, whatever. I don't microscope, whatever. When I can see, I can do it more better. And because of that, I think yes. If we do it under microscope, because we see more better, we can do it exactly, and we can place MTA in the amount that is needed, and we won't use a lot of material, and we will place it exactly in the place that we should do it. Then because of that, I think I really I think that magnification will help us. Yes.
Exactly. I mean, like with you, if we have if we have magnification, we can do the MTA plug or using MTA very more impressive, very more effective, and it will help us to see what's working, what is the working lens, and what's happening inside the root canal.
Sealing a perforation. Do you agree with me? Like, it's perforated, I see it, I can put MTA exactly in the place that it's necessary.
Yeah.
Because of that, yes, I think magnification will help us definitely.
Yeah, exactly. But we have to consider that we still can do and use MTA if we do not have any magnification. It's more technical. It is harder, but still we can use it without magnification. And also we should consider, and we have to mention that we have we may use the MTA in curvature, in tools with curvature, and we are not able to see the apical curvature area if we have a severe curvature, and we still need to rely on our actually tactile sense and our techniques.
Exactly, tactile sense.
Exactly, and we cannot be able to see in spite of having any types of magnification. Very good. And my other question is about you have answered my many questions. I want to talk about the 1 session and 2 visit MT plug placement. Is it necessary to place MT plug in 2 sessions or in 3 sessions? I said 3 sessions because I want to say that in first session you have to place a medicament in the root canal system in order to increase the pH of the root canal system, and in the second session you have to place your MT plug, and you have to wait for 1 week or for 2 or 3 days for the final setting of the MTA, and then you are able to do the final obturation of the root canal system. And this is one of the concepts that some endodontists may follow. Is it necessary to do MTA treatments in 2 or 3 sessions, or we can do it in 1 session? Just disinfect the root canal system with the ordinary protocol and goes for the MT placement and immediately obturate the coronal segment or any part of the remaining area of the root canal system.
Thank you.
Okay. Takashi, if you agree, you can answer
Takashi
my...
starts. Okay.
Yeah.
Okay, thank you. Thank you, Dr. Ali. Medicament?
Yeah, using medicament. Is it necessary to use medicament in every cases before placing the MTA?
If the inflammation is severe, it's better to place medicament because of the acidic environment. Also, it's washed out due to exudate problems. That's why 2 or more visits are recommended. Thank you.
Okay, what is your concept, Dr. Parisa, about using MTA in multiple sessions?
You know, really, when I have a lesion or infection, I agree with Takashi because of the environment that is acidic. I use calcium hydroxide or other medicaments intracanal so that the pH increases and it will be a little bit alkaline. And when the environment is alkaline, I'm sure that I will have a better prognosis. I think using intracanal medicaments in cases that we want to have a better healing, it's a better solution. I use it, but I know that it's not a contraindication. I mean that I know a lot of coworkers, a lot of endodontists that they do all of the MTA placing, backfill, I mean the restoration in just 1 session. And nothing happens, and they even have a lot of successful healing. Then, you know, it's my protocol. It's my way of doing MTA. In my private dental office, I use intracanal medicaments. So I think that I've done my best. And I've done whatever I can. But if the patient is really in some opportunity that she or he can't come back, or I should do it in 1 session, I will take time, but I will use a little bit of medicament in the canal. So I'm so relieved. And then I will place my MTA or other material so I can have a good sealing in the apical segment. Because of that, I think it depends on the case and on the experience. In my experience, I use really medicaments, and I think it's a good opportunity to use it. But maybe some people do not agree with me.
And I'm one of the person that I'm not agree. I shouldn't say I do not agree with that.
People, a lot of endodontists really like
the people that you talked about. Actually,
you know, one of the reasons reasons that endodontists like endo is that they want to complete their patient in just one session.
Exactly.
Of course, when you put medicaments in the canal, you should check the patient again, and the patient will come back to your office. But you can think that it's a good way, so you can see that all of the symptoms have relieved and everything is in a good order. I think as this way.
Exactly. My concept is I try to use MTA in one session as much as possible, but I will do MTA in two sessions in just in case of having a very large periapical lesion, and in case of that we cannot control the drainage and the moisture of the root canal system. If I'm not able to completely control any drainage in the root canal system, I will go to use medicament in order to have a better apical healing and wait 1 week to see the relief of symptoms and the relief of any pains or anything that the patient have, and then I will start my MTA placement in the second visit. But I will do my MTA cases in one session as much as possible because I am the fan of one visit treatment. But if you agree, I want to share some articles and some techniques. As long as I saw in your cases, you use paper points, you use pluggers, and you use gutta-percha in order to put your MTA and to compress it in the root canal system. But I want to share some different techniques, and let's see, okay, what are these types of technique, and I want to share some articles about some of my question. Let me ask my question first. Do you agree to place a glass ionomer immediately after the placement of MTA? For example, you have a vital pulp therapy, you put MTA over your vital tissue, and then you put glass ionomer in order to complete your coronal restoration in one visit. What is your concept? Paris, this time you start.
Me first, I answer.
Yeah. This time you answer.
Dear Dr. Ali, yes, I use a glass ionomer above the MTA in the session. I mean, like I wait about 10 to 15 minutes. Because the brand of MTA that I use in its protocol, it's it has told that it doesn't affect glass ionomer. I mean, it doesn't affect it on the MTA. And because of that, I just seal above the MTA with a glass ionomer, and then in the segments that it's, I mean, like central, lateral, and aesthetic part of the mouth, then we will place even composite in that same session. I mean, everything in one session, glass ionomer and even composite. Because it depends on the brand of the MTA that you use. Like, I don't want to say, but like MTA Angelus that we all know, it's a kind of MTA that we can do it. And even in the protocol or catalog I looked, it has written that the setting time is about 10 to 15 minutes. And even though that the setting time has not reached, you can place glass ionomer because it does not interfere the MTA material. Because of that, yes, I put it immediately on the MTA. This is my protocol. Okay? This is what I do.
Thank you.
In my cases. But I've heard some other articles that say it's better to wait about 45 minutes.
Exactly.
Because of that, you know, I think it depends on the case, on the experience, and on the branding that you are using.
Very good. Thank you. Takashi, what
And
is your
Dr.
idea about?
Takashi, what's your opinion?
Yeah, that's a good point, Dr. Parisa. Yeah, but for me, I don't do it regularly. Mm, but it can be pressed on unsettled MTA if humidity is controlled. But when using putty, balsamic putty in small perforations, place the glass ionomer immediately.
Very good. That's a
Thank you.
good point. Yeah. If you have putty, it is better to use immediately glass ionomer over it. But let me share my cases. Please wait. Okay. Let me share this. This is a very good article that talks. Let me start with this article. Okay. This is a very good article that it was mentioned that you have to use glass ionomer over your MTA after 45 minutes. It was mentioned because of the initial setting of the MTA, you have to wait about 45 minutes to see the initial setting of the MTA and then go for the final actually restoration. And if you put a glass ionomer over the MTA, the brand that was used in this article, you will see that the final setting of the MTA will not be completed. We have the same articles about, for example, about the SEM cement or about the micro hardness of the MTA. In this article, it was shown that if you use glass ionomer over MTA immediately, you will decrease the micro hardness of MTA. So in this article, it was shown again that you have to wait in order to have a better micro hardness of MTA in order to increase it if you want to use glass ionomer over your MTA. And in many articles, it was mentioned that the waiting for the initial setting is necessary in order to have a better properties and better final setting of MTA because the initial setting is very important for the final feature of your MTA. And this is a very good article, and I just want to talk about the indirect use of ultrasonic activation in order to put MTA. In this article, it was shown that if you use indirect ultrasonic placement technique, you will have a better condensity and the volume of MTA in the root canal system if you use indirect placement rather than using direct placement of the MTA in the root canal system. Because of the vibration of ultrasonic, you will have a better adaptation of the MTA to the root canal system. You will have a better sealing in the apical area, and it was suggested to use indirect ultrasonic activation in any way of using MTA in the root canal system. In this article, it was used in retrofilling in microapical surgery, but it was suggested to use indirect ultrasonic activation. For example, if you want to use it in orthograde manner or in any way in the root canal system, it will help you to have a better seal and to have a better adaptation. And this was repeated in many articles in the literature to use indirect ultrasonic placement technique for MTA. And this is another article, and it has a very good result. We have four technique to place MTA in the narrow curved canals. The first technique is I don't know if you have heard about the Lavati technique. Lavati, this technique. I mean, let me show you. It means you use when you use hand file in the root canal system. The terminology is Lavati technique. This is the new terminology that I just hear it in this article, but it was very.
You mean
it is
hand
very familiar.
file in placing
Yes.
MTA?
Yes, you use hand file in order to control and place the MTA in the root canal system. This technique called Lavati. And the other technique is to use gutta percha, and the other technique is to use condenser, and the final technique was to use auger technique.
So
I think you have heard. Yeah. The auger technique is very useful. You can see it here. It was written here. The auger technique is the technique. I will show you a video about this technique. I really like this technique because it is usually used in curved narrow canals. For example, if you want to use MTA in the mesial of the mandibular molar, you can use this technique. It is very useful, and you will have a better adaptation of the MTA in the root canal system. In this technique, you use nickel titanium rotary files in reverse mode, and it will help you to place the MTA in any working length you want to have your MTA. And in this technique, the result is very impressive. It shows that the Lavati technique is more impressive and more efficient than other techniques that were used in narrow curved canal. It was better than auger technique. It was better than the gutta percha technique. It was better than the plugger technique, but it was mentioned that you have to spend more time to use Lavati technique, but it is more actually efficient. And this article and its result was very impressive. It was published on Materials Journal on 2021. It is a very good article. I suggest you to read this article.
The recent article.
Yeah. I want to share you two videos about the use of auger technique. The first technique is to use auger technique. Let me, if it is possible, to show it here for you. Yeah, this is the auger technique. As you see, we have to use rotary files in reverse action. Okay, let me go a bit. Okay, we need to place MTA in the root canal system as apically as possible in the auger technique, and we can condense it as much as possible, but you don't have to condense it completely to be dense completely. You have to just mass of MTA in the root canal system, and then you start to place your MTA in the root canal system by the reverse mode of your rotary files. As you see, the MTA will go in to the apical area, and it was condensed at the apical segment. Especially if you have a narrow curved canal, it is very hard to place the MTA in the working length, in the exact and accurate working length, but the auger technique will help you to put it more accurately and more precise. As you see, you can place your MTA in the root canal system by any carrier you have, condense it a bit, and then use rotary file in a reverse action. Many of my students ask me it is a very dangerous technique, but I want to say that it's not a very dangerous technique. If you know the exact actually working length, you shouldn't be worried about the control of the working length. The reverse action of the rotary file will help you to guide your MTA to your working length very safe and effectively. I really like this technique. And about how to remove the excessive amount of the coronal segment of the MTA that was attached to the wall, you can use micro brush. You have to wet your the tip of your micro brush, and you can use it in order to completely clean the coronal segment of the root canal system. This was a very good technique, auger technique. And the other technique is to use a sponge. If you have lateral perforation like this, you can use a sponge in the apical part of the perforation. The sponge will help you to have a seat, and will actually block the main pass of the root canal system and help you to put your MTA at the place. It can be perforation, it can be any internal root resorption or anything. The sponge, or as you see in this video, it was placed apical to the perforation side, and it will block the main path, and then you can easily insert your MTA in the perforation area here, and then condense it as much as possible.
But in this case, I think magnification is really a helpful instrument because
that's the magic
will block it.
Exactly. That's the magic of magnification, because you can see the exact point that you place your MTA in the root canal system, and you can completely have a control on your MTA placement. But as you see in this video, the paper point was used to completely dense the MTA, and the way that was suggested to remove the sponge in the root canal was to use lentolo as a carb screw. Yeah, because if you use any file or any plugger to remove the sponge in the root canal system, you may push it more apically and you may block completely the root canal system. Yeah, as you see, we have in this case 2 lateral perforation, and we can use a sponge technique in order to block the main canal, and then to place the MTA in the perforation separately. You can completely manage the 2 lateral perforations separately very effectively by this technique. I really like this technique, but as Dr. Parisa mentioned, you should have magnification, especially a microscope, because dental operating microscope will help you to have a better vision in the root canal system in the more apical area. As you see here, it was easily placed in the lateral perforation, and finally, by using the lentilo, you can remove the sponge in the root canal system by corkscrew action, like this.
Yes.
The most dangerous part of this technique is to push the sponge in the more apical area, and you may not be able to remove the sponge completely. But as you see, the lateral perforation was managed very effectively and very easily. Okay, let me turn back my
especially the point that you told us about the sponge putting in the root canal, so that we can have a very good seal in the perforation. That's like a strip perforation or other kinds of perforation, in especially I think curved and very tiny canals.
Exactly.
Yes, it's a very useful technique.
Thank you.
That's amazing.
Thank you. I really like the auger technique. I just wanted to share it to see how it is very effective, and you can use it in your daily cases if you have MTA plug cases. And there is a question in the comment I want to ask you about use MTA putty, which has required flow already, and then use the reverse rotary. Is it possible to use auger technique for putty type of the MTA or not? In my opinion, you can use the reverse rotary file for putty, because there is no much difference about the flowability and the handling of the MTA-like material. But for the putty, the main advantage that you can exactly. Thank you. I think the brand is Marucci. I think it is Marucci MTA putty. Exactly.
Yes.
Yeah, MTA putty.
MTA putty. Very good. Yeah. It is more user friendly.
Something special about the putty type or putty type is that it's a kind of moldable, so it does not wash out.
Exactly.
It's good.
It's very good. You can use it anywhere you want.
It's really easy to use.
Yeah,
but it's
expensive.
Don't forget it. It's expensive.
The main disadvantage of putty is it is cost, because it is it costs very high. But for example, if you have any apical microsurgery, you can shape it in any way you want, and you can place it in the apical area retrograde very effectively and very easily. It will help you to have a better
exactly
apical microsurgery.
You can use it immediately, and it's a kind of moldable. It's like a mold. You can put it and exactly in the place that you want. and
It's a
it's
very
good.
good.
And even I think that it tells us that it does not have any discoloration.
Yeah, the new generation of the putty MT materials doesn't discolorate the tooth. The main advantage
Yes,
of the older generation of MTA is the discoloration of the tooth, but the newer generation bioceramic like materials and also biodentin, for example, we can say that we may not have any discoloration of the tooth in the long term.
exactly.
Exactly. Very, very good. Okay. Uh, is there any question about what we have talked about, or
We have
yeah,
answered a lot of questions.
yeah, thank you. It was a very good discussion, and it was a very good case-based actually conversation. And I liked your cases. I liked your knowledge, and thanks for your generosity towards you sharing your experience and your knowledge for this session. Okay, I want to ask all the audiences if they have any question, we can go or we can finish the session. I think we have answered the question that was asked. Is it useful to use collagen matrix in these cases? Actually, we can. My answer is that we can use collagen matrix anywhere that we may think about how to control the working lens, or we don't have enough apical or any stop in order to place the MTA. You can use it anywhere you want, but you have to keep in mind that using any membrane, for example, Collacord or PRP or PRF in the root canal system is very hard because it is very technique sensitive. It is sticky. You may not be able to use it in narrow canals. You can use it only in big areas or in big perforation or in big apical lesions. You cannot be able to use it in actually narrow canals because it is hard to place it in the apical area at the exact working lens.
And I think, sorry, Dr. Ali, it's
Yeah.
not a common mishap for us. Like, endodontists, after a while that we experience and we try to use MTA, we know how to press it, and the tactile sense will help us. So I think it's not that such a problem for us to control the MTA. Maybe as a beginner, it is a challenge, but after some cases that we try to use it, it will be okay. And we know with which tactile sense and with which pressure we can control the MTA to the working length. Okay, maybe I have a case, and I even have it on my laptop. If you want, I can share it with you guys. I have extruded a lot of MTA beyond the apex, but my patient is good and nothing has happened because these kinds of material are very biocompatible. And after a while, you learn how to control the MTA so it will not be extruded. But of course, using some collagen, collagate, or PRF materials are good, so we can control it. But learning how to control your touch, your sense, and how you use to put MTA in the canal is a very easy technique, but you should do it every day routinely so we can learn it. And after all of this, I think it's not such a big deal.
Exactly. One of the criteria is your actually skill and your experience in using MTA. But for me, I
because
use
it's technique sensitive. It depends on the technique.
Exactly. I just use it in very large, actually, apical size. We have a blunderbuss apical area, and
I really I agree with in these cases. I think we should use like collagen or collagen, but in the daily routine I really don't use it. Like I think
exactly.
it's not that necessary.
Yeah, just for
Uh,
a few cases.
I'd like to add. Okay.
Okay, go on. Thank you. If you have any comment, you
As
can add.
I mentioned earlier, I guess collagen matrix is very important. It can be used anywhere, including in reps, regenerative endodontics.
Exactly.
Thank you.
Thank
We
you. Thank you.
use
Yeah.
it. Yes, we use it in reps, regenerative endodontics also.
Yeah, it's a good material because a good bioactive material. It has a role of actually it can be a scaffold in the regenerative endodontics
Exactly,
in
it's a
order
kind
to
of a scaffold
it's type of the
and
scaffold in the
resorbs
regenerative endodontics.
and even induces the stem cells over there. So it's a very good material. But I mean, after a while that we use our techniques and we do it routinely, we can manage these kinds of cases, even though that we don't use that kind of absorptive matrices. But it's a good choice. Like
Yeah,
putting or everything that we have around that are very good material that we can choose them in the case that it's needed.
yeah,
Yeah.
because as you all are as all of us know, and we want to have a control on the working list. We want to control MTA placement. We know that it is biocompatible. There is no worries about to push it over the apical or over the root canal system, but we want to have a better control on the apical placement of the MTA, and we can use it as an adjunctive material in order to have a better control on your workingness if you want to place MTA. And recently I have read an article about the gross overfilling of the MTA. If you have a gross amount of overfilling of MTA, we may also have some inflammatory reaction in the body because the body may not be capable of tolerating those mass amount of the MTA extrusion. So we should have the control, and we have to control the extrusion amount as small as possible, and collar coat or any membrane will help us to have a better control over the extrusion of these bioactive materials.
And of course, we really don't want to have extruded material. None of us.
Exactly.
None of us don't want to go beyond the apex, and we shouldn't. And even a tiny piece, when it goes extruded, we will be nervous, really. But I'm so happy that these kinds of material are so biocompatible
Exactly.
and our body really tolerates it. And we even see such a successful, follow-ups after 2 or 3 years that the body has tolerated it and everything is in a good situation. Because of that, I don't agree that we should push it away the apex, but we can control it. But if it happens, I think because of the base of the material, it's not such a big deal.
Exactly. It is very good that we have the chance of having success cases in spite of having over extrusion of bioactive materials in these cases, and it is a good chance for us that having such biocompatible material. It was question about the WITOPEX over MTA in pedo patients. Actually, I don't have any knowledge about the pediatric dentistry, but as long as I know, WITOPEX is something different from other bioactive materials. It is only used in deciduous teeth, and it is not used in mature teeth, and it is not recommended to use WITOPEX in mature teeth in order to have any type of treatment. This is my knowledge, but I want to ask you to answer this question if you know anything about topics over in, yeah. Do you have any idea about using topics over the MTA in pedo patient?
We have materials such as MTA. We don't use Vitapex.
Yeah, that's my concept. If we have good materials like that, we don't need to go for Vitapex, but as long as I know. Go on. Okay.
Go under absorption, you know, the
exactly.
tooth is grown and we have roots.
Yeah, the main advantage of using Vitapex in DCDS is it absorbs in the long term, and
exactly.
It will
but we don't need it.
In
permanent tooth.
For the permanent teeth to erupt completely. This is the main advantage of using MTA in DCDS. Dr. Takashi, do you have any idea about Vitapex?
That's why medicament is needed.
Yeah, so
you know,
you don't use
Vitapex is the ingredient of Vitapex is the calcium hydroxide, and
exactly.
They use it as a medicament, but we don't use it as a permanent filling. Don't forget it. You know, the person that asked this question, and in the permanent tooth, we want to have something like MTA, so we can have a good seal. Good, and after follow-ups, we don't want to see that our material has gone.
Exactly.
And
it's not reasonable to use in permanent.
And one of the advantages of MTA beyond calcium hydroxide that traditionally was used was exactly this. They put calcium hydroxide in the canal, and then they followed up the patient, and they would see that the tooth is getting weak. You know what I mean? And it needed a lot of follow-up. But nowadays, why we should put calcium hydroxide to make a kind of hydroxyapatite seat? We don't really need it. With materials like MTA biodentin and other these kinds of materials, we can put it and make an apical seat, and there's no need for these kinds of medicaments that are not, they're just temporary. And
exactly. That was Frank technique. In the past, we use long-term calcium hydroxide therapy to see the apical barrier, and then we go to use.
And first of all, that was introduced, and then it switched to these kinds of materials. Like I think it was 1993 that MTA was introduced, and it was really good. Yeah. It was fantastic.
Using calcium hydroxide is an obsolete technique, and it is not recommended in the contemporary endodontics.
Exactly.
We have talked about the indications of MTA. I asked you to see the saved live webinar because there was a question about the indication of MTA. We have talked about it. You can see the saved live webinar. There is no time to answer this question. Okay, I think there is no other new question that we haven't talked about. Very good. Thanks for your dedication towards this program. It was a great conversation with you guys, my friends Takashi and Parisa. I was honored that I have the chance of learning from your skills, from your experiences, from your knowledge. We have actually evaluated very impressive cases, and then we have talked about our concept and our techniques in placing the MTA in and using MTA in the endodontics. We don't have enough time to talk about using MTA in any field of endodontics. For example, how to use it in perforation, how to use it in, for example, strip perforation or other area of endodontics. Maybe in the future session and appointment we can talk about this. But I think it is enough for this session. It was very good and informative, and we have an insightful discussion about the art of using MTA in the endodontics. I just want to thank you and say that we are looking forward to seeing you in the next programs. EndoLeaderShow the teams is going to have very actually large and very big shows and programs in the near future. Stay tuned for the upcoming events, and we will see each other again in a bigger project and in a bigger conversation
I hope
sessions.
soon. And thanks, dear Takashi, for being with us. We had a very great time with you. Thanks, dear Dr. Ali. Good luck for you. I know that you're always doing a very fantastic work. I hope you good luck.
Thank you.
Thank you so much.
My honor.
Thank you so much for inviting me.
That I have a talented and esteemed endodontist friends like you, Takashi and Parisa. Have a good day. I will finish this session. Wish you the best and see you soon in the near future programs. Bye till then.
Hope to see you soon. Bye.
Hope to see you
Thank
soon.
you.
Bye.
Great time.
Great time. Have a good time.